everyone, it's Olivia from the New England QIN-QIO. We're going to go ahead and get started. I'm going to introduce Rakotz, who's from the New England QIN-QIO, who will open up the webinar. Again, we are having some issues with background noise on our phone. We have gone ahead and manually muted everyone. There are some lines coming through, so please go ahead and manually mute your phone if you are not a presenter. If you are a presenter, please press #6 to unmute yourself, and welcome, Abby.
Hi everyone, good afternoon. My name is Rakotz from the New England QIN-QIO, and I'll be your moderator for today's webinar, Target BP, Help Your Patients Move Toward Controlled Blood Pressure. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. We're co-hosting today's webinar along with the American Heart Association, the American Medical Association, and Quality Insights QIN-QIO. So thank you all for joining us for today's webinar. Before we get started, we just have a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with the details on accessing the recording at the end of this webinar. The phone lines will be on mute, as Olivia mentioned, during the duration of the presentation, and we'll take questions at a designated time during the presentation. We'll provide you instructions on how you can ask a question either over the phone line, or you can pose a question in the chat box on the right-hand side of your screen. So at this time, I'd like to introduce you to our presenter today, Dr. Michael Rakotz. Dr. Rakotz has been a practicing family physician for 18 years. He recently served as Director of Population Health and Virtual Medicine at Northwestern Memorial Physicians Group in Evanston, Illinois. And he is an ONC Health IT Vanguard Fellow working with the Chicago Health IT Regional Extension Center to help kickstart their Million Hearts program for small independent practices in the metro Chicago area. At the American Medical Association, Dr. Rakotz serves as the Vice President of Chronic Disease Prevention and Management Strategy for improving health outcomes, focusing his efforts on helping to improve blood pressure control nationally. Now, without further ado, Dr. Rakotz, the floor is yours. And you can go ahead and press #6 on your phone line to unmute.
Thank you very much. Can you hear me okay?
Yes, thank you so much.
Okay, great. Well, thank you very much for having us today. We're very pleased to be giving this presentation. So just briefly go through the objectives for today. I'm going to describe the impact of uncontrolled blood pressure from a public health perspective and from a patient's perspective. We'll review how the Target BP initiative can help with your practice's blood pressure improvement efforts, and then we'll identify evidence-based best practices that practice sites can use to improve blood pressure control, including what we call the MAP checklist, and I'll go through those in some detail. So the reason that we're here today is we really want to emphasize and bring back to the forefront in everyone's mind the importance of high blood pressure. This is the current classification of blood pressure it really hasn't changed since JNC7 in 2003. 1 in 3 American adults have high blood pressure, which is a blood pressure that runs greater than 140 over 90 millimeters of mercury. And according to the latest statistics from the American Heart Association, the 2017 update for heart disease and stroke statistics, there are now 85.7 million U.S. adults age greater than 20 with hypertension. This is extrapolated from 2011 to 2014 NHANES data, which show that roughly the prevalence rate for the United States is 34% of adults now have hypertension. So this is a little bit higher than the last NHANES data set. So the prevalence of hypertension continues to rise in the United States, but still roughly 1 in 3 adults, so extremely important. The projections show that if the current trend continues, by 2030, we'll have 41.4% of the U.S. adults with hypertension. So something that we really need to improve our efforts to control in the immediate future, or we're going to start to see many more heart attacks, strokes, and premature deaths due to cardiovascular disease and stroke, and the other complications related to high blood pressure. So here, this is looking at a slightly different way the prevalence of hypertension laid out by gender and age. What I want you to notice is that hypertension, in men, the blue bars, is more prevalent up to age 64. It's more common in men, but after age 64, the red bars, women, hypertension becomes more common in women after age 64. So skewed more towards men under age 64, and then skewed more towards women over age 64. The other thing that I think is probably even more impressive when you look at this bar graph is that starting somewhere between age 50 and 55, about half of U.S. adults will have hypertension, and it continues to go up after that, and by the time somebody in the United States, an adult, reaches age 75, more than 75% of the U.S. population will have hypertension. So pretty amazing how the prevalence changes with age in the United States, and we need to remember that in practice. On the next slide, and I apologize, this is a busy slide, but this looks at awareness, treatment, and control, and it breaks it down by race, ethnicity, and gender. And what we can glean from this slide is that we're doing an okay job. Overall, 84% of adults are aware that they have hypertension, and so that's not a bad job. And what awareness means is essentially that they're diagnosed. They've been told more than once that they have hypertension, or they're on a medication to treat hypertension. So that equates to being diagnosed with hypertension. So 84% is not bad, and 76% of adults with hypertension are under treatment, so are being treated for hypertension. And that's not bad either. The problem comes when you look at the green bars for control rates of hypertension, and the average in the United States for those 85.7 million people currently is 54.4% of people with hypertension or high blood pressure in the United States have their blood pressure treated to goal. And that's something that, although we've come a long way in the last 30, 40 years, is really not acceptable. About half of the people with high blood pressure are treated to goal. And there are significant variations across racial ethnic groups, and you'll notice that approximately 10% lower control in men compared to women in almost all of the racial ethnic groups, and on average it's about 10%. In some cases significantly higher than that, the difference between men and women. And on the next slide, I wanted to show you that if you look at the annual number of deaths over the last 14 years, from 2000 to 2014, you can see a significant increase in the number of deaths due to hypertension. Now, this is largely due to our aging population and obesity increasing in this country, but that really doesn't tell the whole story because, the age-adjusted death rate is also on the rise. And one of the really staggering statistics is that during the same time period, age-adjusted all-cause mortality rates have gone down 21% during this time, at a time when hypertension-related death rates had increased 23.1%. In other words, deaths due to, if you include cancer and all causes of death, have decreased. We've done a great job reducing heart attacks. Treatment for cancer has improved. So we've got a 21% decrease in the death rate, yet deaths related to hypertension like strokes and heart failure and chronic kidney disease and end-stage renal disease, deaths related to those things have gone up 23%. So, we've really got a lot of work to do in this area, and this goes back to that 54% control rate. With 85.7 million people and only half of them at goal, we're going to continue to see significant death and morbidity due to uncontrolled high blood pressure. In addition to the health factors, we also see that there's an increasing cost associated, directly and indirectly with hypertension. We can see in 2011, the direct and indirect cost was $46.4 billion. And in 2012, these are the latest statistics that we have, the cost went up to $51.2 billion, and the projection for direct costs only for 2030 is over $200 billion. Some estimates for direct and indirect costs by 2030 are over $300, maybe $400 billion. So again, this is something that we can prevent if we can do a better job at controlling blood pressure, and that's one of the reasons that we're on the call and that we have this initiative to try to improve health through better blood pressure control, try to reduce cost at the same time. And when I was talking about the age-adjusted death rate relating to hypertension-related causes, what you see on the right here, the arrow going up at 7.6%, that's what we've seen over that same time period for age-adjusted death rates specifically attributed to hypertension. So not hypertension-related causes like heart failure and kidney disease, but just hypertension alone. And we see that that's going up as well over that same time period. So, deaths attributed specifically to hypertension are significant. It's really all telling the same story, that we really need to do more about controlling blood pressure. And that's one of the reasons that the AMA and the AHA got together to create Target BP. So back in November of 2015, the American Medical Association, American Heart Association, and Scientific Sessions announced the Target BP initiative, and we've been ramping this initiative up since then. And Target BP really is three things. It's first, it's a call to action to motivate medical practices, practitioners, health services organizations to prioritize blood pressure control, again, to bring it top of mind and make it a priority again in medical practices and in the public, really. We really want to make hypertension a priority. Second, a recognition program and recognizing healthcare providers to attain high levels of blood pressure control in their populations, particularly those who achieve a 70% or greater control rate. Third, we want to provide tools and assets, resources for providers and health systems and practices to use so they can attain those high levels of control in their patients with hypertension. These include things like the AHA, ACC, CDC, hypertension treatment algorithm, and the AMA's MAP checklist, which again we'll go through in a little more detail shortly. But there is a website for Target BP, which is targetbp.org, where all of this information is housed. So the target audience is really the primary care system in the United States. So federally qualified health centers, federally designated rural health clinics, Indian Health Service, and really any primary care medical center or clinic practices that are publicly run, underinsured, the clinics that serve the underinsured, QINs and QIOs, and private practices and private clinic systems. So any government agencies or other organizations as well. This is really any primary care system is really who Target BP wants to reach. So when we talk about our recognition program, why should a clinic participate in Target BP? Well, we know that medication works, but we don't have the systems in place to drive control rates. And this is one of the things that we'll talk about. We've got treatment algorithms and systems approach that are described in the AHA's treatment algorithm that have been proven to increase control rates within a clinical setting. And we look at this as the playbook to guide clinicians on improving blood pressure control. It really makes a big difference when they know who to treat, when to treat, when to see the patients back. Also, benefits include, recognition from the American Heart Association and the American Medical Association for participating and achieving higher blood pressure control rates, and as well as helping meet required performance metrics like PQRS measures, HEDIS measures, and NQF measures that can be tied to value-based care. And most importantly, participation that leads to improvement in control rates will lead to improved health care for your patients, which really is the most important reason why you would participate in Target BP. So the recognition program is slated to kick off in really coming up in March. In 2017, which will be submitting 2016 data, there are two levels of recognition. One is for participation in the recognition program. Again, you submit 2016 data, and then there's achievement. Anybody who participates in the recognition program submits their data, which is NQF-18 or PQR-236, the measure for blood pressure control, and achieves a greater than 70 or equal to 70% control rate in the adult population with a diagnosis of hypertension, where the last visit was less than 140/90. In 2016, if you achieve a greater than 70% control rate, you will have achieved, across your population, you will have achieved that level of recognition. This is just for our first year that we're doing this in 2017 for 2016 data. In the future, we'll likely have recognition for 80% and higher, as well as improvement levels and some other metrics that we'll have. So we're starting off with a very basic level of recognition, hoping to build out the recognition program as time goes on. The data submission requirements for joining the recognition program really can happen at the time of registration or after registration between March 31st and July 31st. Registration data, is very similar to the recognition data. The recognition data will assume a level of validation that we have. It's a very simple data validation process that will be built right into the website when you go to enter your data. And if you register before March 31st, you'll get an email notifying that you can now submit your registration data. Your recognition data. And the recognition data really is just for your adult population to enter your adults stratified by age, your total patient population by ethnicity, the total number of patients with the diagnosis of hypertension in your population in the practice setting, and the total number of patients with the diagnosis of hypertension whose blood pressure is controlled. These are really the main data elements for the recognition program. We try to keep it simple. You'll have a chance to do that starting at the end of March. And, we'll have the webinar in early April to explain how to do this specifically, and the AHA affiliate staff will be available for anybody who registers for Target BP to explain how this process is done in more detail. But if you're interested, talk to the affiliate staff about joining the recognition program and Target BP. The recognition will be, again, very simple to do and really worthwhile to be recognized for participating in the program. And now let's talk about some of the improvement tools and why you can, if you join Target BP, some of the benefits of improving blood pressure control in your population, how that would happen. So we know that why do we have a 54% control rate in the United States? It seems so simple. We know how to treat blood pressure. We know how to diagnose high blood pressure. But yet we're just sort of stuck at this 54% control rate for the last several years. But there are several reasons and barriers that we face. There are patient factors. We've got non-adherence is a big issue for both lifestyle change and medication non-adherence, so treatment non-adherence. There are financial factors. Treatment is costly. Office visits can be costly in certain areas. There's literacy issues. And there's physician factors. Physicians are pressed for time. They've got financial factors. They've got to see a lot of patients. There's competing factors during office visits. And then there's system factors. There's some offices have better quality reporting and dashboards to help providers than others. Workflow in some offices is better. There's more TeamBased Care in some systems that really can lead to better management of hypertension. And then there's leadership. Sometimes you have buy-in and sometimes you don't. And if, there's a discrepancy, if you have leadership buy-in who's willing to participate, again, in promoting team-based care and the tools that you need to improve, the population health and dashboards, it can really make a huge difference. So several factors. So one of the things that we did 3 years ago in our work here with Johns Hopkins was to develop a framework of improvement. And this will actually be, the MAP framework stands for measure blood pressure accurately every time, act rapidly to manage uncontrolled patients with hypertension, and partner with patients, families, and communities to promote self-management. The creation of this framework is actually going to be published next month in the Journal of Clinical Hypertension. It's an interesting story, based on the evidence why we came up with this framework, but this is three very simple strategies for improving blood pressure control and centered around using actionable data, using evidence-based tools to improve, and delivering this through team-based care. So I'm going to take you through, we took this framework and we needed to be able to operationalize it in a clinical setting. So we took the MAP framework and created the MAP checklist for improving blood pressure control. And these are three very simple checklists, and it looks a little busy on this slide, but the non-grayed out areas, really there are only a few boxes that can walk you through the steps of the keys to improving blood pressure control that, again, essentially focus on measuring, blood pressure accurately, which is rarely done globally. Most blood pressure measurements are not accurate. Again, we've got another publication coming out probably in the next 2 months on unfortunately, how accurate measurement in blood pressure rarely occurs. The importance of acting rapidly, to go through in a little more detail, really has to do with reducing hesitancy to treat and the importance of using a treatment algorithm. And finally, partnering with patients really is about empowering patients to self-manage. And let's go through each of those checklists in a little more detail. So why is measuring blood pressure accurately so important? I mean, I know it's common sense. We all know that this is really critical, but due to the naturally occurring blood pressure variability that occurs in everybody, a snapshot in time of taking somebody's blood pressure is really not the best way to understand what somebody's true blood pressure is. And so blood pressure is constantly changing minute to minute, hour to hour. So looking at a single blood pressure or multiple blood pressures, even in a clinical setting, there's often a lot of uncertainty about, does this represent what the person's true blood pressure really is? That uncertainty is a leading cause for failure of a clinician to act on a high blood pressure in a clinical setting. And what contributes to this, in addition to that uncertainty based around the measurement due to variability, is uncertainty around the measurement due to poor technique. Because again, I'm probably not telling you for the first time that the way blood pressure is measured is extremely variable and unreliable in the clinical setting, and it can lead to poor decision making. So we need accurate, reliable blood pressure measurements to make sound clinical decisions. That's really the takeaway from this slide and from the checklist. So common errors made during office blood pressure measurement are that, the number one error is that the wrong cuff size is used. Cuffs can be placed over clothing, patient improperly positioned, most commonly on an exam table with their feet not on the floor, and their back not supported, and their arm not supported. No rest period. People should be rested for several minutes prior to a measurement. Terminal digit preference, people rounding blood pressure numbers down to 0 or up to 0. Talking during the measurement, and then poor technique, rapid blood pressure cuff deflation during the measurement if using a manual technique. Patient factors including having a full bladder, being on caffeine, having recently used nicotine, recent exercise, a recent meal, or even talking or listening during the measurement can impact blood pressure. And then there are system factors which have to do with where the monitor is located, if it's mounted on a wall over an exam table, if the blood pressure is being measured in a noisy place, or not allowing for a proper rest period. Workflows can have a big factor as well. So we created our checklist to try to address some of these things. And what we came up with was, it has been really starting to be recommended in most international guidelines now and some national guidelines in the United States that using an automated blood pressure device really reduces human error. It's very difficult to take a good manual blood pressure. So using automated devices is really important. So an automated, validated upper arm blood pressure device having the patient sitting in a chair with proper back and arm support, with legs uncrossed and feet flat on the ground, with a properly sized cuff over a bare arm, no talking during the measurement. These things are really important. And if that initial screening blood pressure is elevated, greater than 140/90, we recommend using a device that can take multiple measurements after a 5-minute rest, after the patient empties their bladder, taking at least 3 measurements and averaging them, preferably with no one present in the room, which is the protocol that was done in the SPRINT trial, which virtually eliminates white coat effect if you have a machine that can do that. And if you don't, there's still benefits taking multiple measurements and then averaging them. That will give you a much more representative blood pressure than that single screening blood pressure, even two screening blood pressures. So measuring accurately, extremely important. Doing a few things to do it right can increase the representativeness of the blood pressure for that person. Moving on to the, when we start to talk about reasons why physicians and clinicians fail to act on high blood pressure, the most common reason that clinicians fail to act on an elevated blood pressure, greater than 140/90, I told you that they really they doubt that the blood pressure measurement is accurate, and so they fail to initiate or escalate therapy when they're faced with an elevated blood pressure. The second factor that contributes to a missed opportunity is that they fail to stress the time when follow-up is needed, so failing to stress frequent follow-up. So those two things, failing to act in the moment, failing to schedule frequent follow-up, together are known as therapeutic inertia or clinical inertia. And this is thought to be one of the leading reasons of uncontrolled blood pressure. The other factor that we already mentioned briefly is non-adherence to treatment plans, and these two things usually go hand in hand, especially these days with shared care plans. The busier a clinician is, the less likely they are to spend more time talking about the importance of medication adherence and assessing whether or not, what is the risk of medication non-adherence. And so, there are several other factors that contribute to treatment adherence that need to be addressed that often aren't. Very challenging problems. So clinical inertia, extremely important to try to address, and we're going to the reason that we created the Act Rapidly checklist was to try to reduce clinical inertia, and I'm going to take you through some of the steps there. So, again, we mentioned factors contributing to clinical inertia and therapeutic inertia. From the clinician's perspective, failing to initiate or escalating therapy when indicated happens all the time. A lot of times this is due to competing factors. The patient may be in for several diagnoses at the same time, need several refills. You've got about 7 minutes or 5 minutes or less in the exam rooms. You may not understand, why the patient is in. You may not notice that the blood pressure is elevated. The patient, may argue or not want to take the medication, in which case it may be difficult. We see this all the time where we've got clinicians wanting to initiate treatment, patients not wanting to initiate treatment. So, this is a significant factor, especially when you're time crunched. So, physician factors, clinician factors, really one part of this. On the patient side, probably the leading reason, there are no symptoms for most people with high blood pressure. So, that's absence of symptoms is a really big part of the problem. Cost of medication, another part of the problem. Multiple medications, side effects from medications. These things are all reasons that patient factors contributing to uncontrolled blood pressure. So this is really a significant problem. And then there's system factors, which are briefly mentioned. Sometimes there's care coordination, sometimes there's not. Sometimes you've got, the buy-in we talked about. Sometimes there's good communication with clinical staff and great workflows in the disease registry, population health management, and outreach. And sometimes there's none of those things. And so these system factors can be, sometimes there's an institutional treatment algorithm, sometimes there's not. So the system factors can be a big part of whether or not there is better blood pressure control at one practice or health center versus another. So these are all important factors. So when we're trying to reduce clinical inertia, having a standardized treatment protocol is a huge part of this. The evidence has shown that using standardized treatment protocols really does improve blood pressure control. This has been shown in the literature. And like I said, it's like a playbook. It tells you when people need treatment, so who needs treatment, when they need it, what to treat it with, what to treat them with medication-wise and lifestyle-wise, and when you need to see them back is a key component. So all of these things are encompassed in the AHA, ACC, CDC treatment algorithm, which we're really promoting as a big part of our program. And, the reason being that, delays in initiating treatment can lead to morbidity and mortality, and, delays in intensifying treatment when blood pressure is uncontrolled, and delays in follow-up can also lead to increased morbidity and mortality. So these things are absolutely crucial, and by having a treatment algorithm, it really makes your job a lot easier. And finally, the third part of our checklist is partnering with patients, families, and communities. And again, this checklist is really designed to empower patients to self-manage and to reduce treatment non-adherence. So one of the ways that we do this is to recommend using evidence-based communication strategies. And really, this is about clinicians talking less and listening more, and trying to engage patients in communication to try to tease out why they may or may not be following therapy, what they are or are not willing to do in treatment, so you can find out on the front end what they're willing to do, and then when you've initiated treatment, to use a different style of communication to find out how things are going. So, for example, we put in this box some the five, really they're more, you can call them techniques, you can call them strategies. I like to call them the five skills to use. So using open-ended questions for things like asking about whether or not they're taking their medications. You really don't want to ask a yes or no question like, are you taking your medication every day? But if you say something like, how's it going with your medication, you might find out a whole lot more information, like if there's side effects or other issues. Directly exploring reasons for possible non-adherence as opposed to not even mentioning it. Again, by just going with a yes or no question on are you taking your medicines, you might not do that. Really important to either assess risk or explore reasons for possible non-adherence to know how to best treat your patient and have better adherence. And then asking patients, eliciting their views about treatment options. You'll know whether or not they're even willing to participate in certain types of treatment. Instead of giving them a treatment they're absolutely not going to participate in, but you didn't ask, so you have no chance of success there. It doesn't mean that patients get to exclusively decide what they will or won't do, but you won't know if they have a problem with it to have a discussion where you might be able to have a two-way conversation about what's best for them. You won't know they have a concern about it unless you have that conversation. And I think one of the most important things is remaining non-judgmental at all times, something that not all clinicians are great at. I know that was, for a lot of my career was a hard part for me. It was very difficult to watch somebody that had high blood pressure not want to initiate medication management for long periods of time or ever. But if you want to have a chance to bring them back around and eventually get them on medication, you need to maintain a strong relationship. And then finally, a technique called teach back, where at the end of the visit, instead of just printing out an after visit summary or writing some instructions, you actually ask, what is it that you learned today from our visit and what is the plan, and they actually have to verbally repeat it back to you. You don't necessarily have to do this. You could have your staff do this, but I think it's really important, and I think you'll learn a lot about what has been retained from the visit. So another really important part of what we like to recommend is self-measured blood pressure monitoring or home blood pressure monitoring. We call it SMBP for self-measured blood pressure monitoring. This is something that's extremely useful for several reasons. Measuring blood pressure outside of the clinical setting has the ability to give you more blood pressures over a longer period of time in a place where the person lives. So by doing that, you'll get a much better idea of what their blood pressure is in real life instead of what blood pressure is like in the clinical setting. So it can provide a better assessment of how blood pressure control is in real life and in different settings and over long periods of time. And for some reason, by putting their arm into a blood pressure device many times over a longer period empowers people to self-manage and get involved in their care. And there is some evidence that improves medication adherence, and we know from the evidence that it improves blood pressure control. So it's something that is absolutely worth pursuing. It also enables people to take a look at how their behavior, whether it's exercise, whether they're exercising more, and how stressed, and how smoking, and how if they smoke, and how eating too much salt can affect their blood pressure sort of more in real time. And it also allows, if blood pressures are high and these blood pressures are communicated back to the clinical setting, it allows for making adjustments between visits so that medications and treatments can be more rapidly escalated if needed to get people under control more quickly. And this has been demonstrated in several studies as well. So there are some definite advantages to self-measuring blood pressure. In how to use self-measured blood pressure monitoring in clinical practice, we've got a nice guide for that and plenty of information available. We can talk to you about that. We're working on some new materials, but in general, one thing that's really important is that proper technique is learned, and that that you need to learn. You need to teach your patients how to do this properly. They need to get a device that fits. They need to measure at the right frequency and report these blood pressures back to the clinical setting. We know that there is sufficient evidence to recommend home blood pressure monitoring with a little bit of education, but there is strong evidence to support using home blood pressure monitoring with additional clinical support. And that are things like using electronic transmission of the home blood pressures back to the clinical setting, having classes to discuss this, more education, one-on-one education to talk about how to do this properly and talk about lifestyle change, et cetera. So using additional clinical support and getting the blood pressures back to the clinical setting is really a critical part of maximizing the benefit of home blood pressure monitoring. And finally, just on the last slide here, before we go to questions, I just wanted to briefly talk about the importance of promoting healthy lifestyles for your patients. We know that healthy diets like the DASH diet, some patients actually can see up to a double-digit drop in blood pressures depending on where they start and how much sodium intake they have at the beginning. But in general, we know that the DASH diet with a low sodium diet can really equal, a blood pressure drop equal in some cases to taking a medication. And we know that people don't like taking medications, and so by having people eat a healthy diet and a low sodium diet and losing weight to achieve an ideal body weight, or even losing 5 kilograms of weight, helps lower blood pressure. Aerobic exercise is recommended in the AHA guideline for lifestyle for improving blood pressure, and a more recent study just came out confirming that aerobic exercise really is the best way to exercise and improve blood pressure control. We also recommend alcohol in moderation. That's less than 2 or less drinks a day for a man, 1 drink a day or less for a woman, and then we always recommend no tobacco use. So I'm going to stop there so that we have plenty of time for questions, and I'm going to hand it back over to Olivia to take those questions.
Thank you, Dr. Rakotz, for a great and informative presentation. So at this time, we will go over a couple questions that were submitted in advance of this webinar. So Dr. Rakotz, if you don't mind, I'll go ahead and read a question to you. And then after we go through these submitted questions, or during, feel free to start typing any questions you might have to all attendees right now in the chat box on the right-hand side of your screen, and if we have time, we will definitely get to them. I will say we will get to as many questions as we can. So just to get started, Dr. Rakotz, we had a couple questions come in along the same theme of patient non-adherence, and I know you touched on this during the webinar, but one question was, what should a provider organization do when the providers have already tried education with the patients, motivational interviewing, trying to address any other barriers to adherence, but it seems like the patient doesn't want to change?
So, the most important part is to find out why. Often, I need to know a little more details. If the patient doesn't want to change their, if we're talking about medication, or are we talking about lifestyle? If we're talking about medication, it might be that they don't believe in medication and they absolutely don't want to do it. They need to be educated about the repercussions of not having controlled blood pressure, the benefits of lifestyle change in lowering blood pressure always, because that's always the first line treatment and needs to be continued regardless of whether medication is recommended. But the barriers, that we know of, cost is one of the biggest ones, multiple medications, another, side effects, another, all things which can be addressed. So if you go from multiple medications that are brand to a generic single pill combination that doesn't cause side effects, you might have a chance. I'm not sure, I need to know a little more specifically what the question is, but these are the most common things that we see that can get people to be more adherent to treatment. And the biggest one really is just communicating about trying to understand why the person doesn't want to take the medication.
Thank you so much, Dr. Rakotz, for covering that in detail. The question was broad and did mention lack of adherence to diet, exercise, and medications. So thank you for touching on all those things. We did have another question regarding walk-in visits. So when patients show up as walk-in visits, what are, or if there are any creative ways in which care teams can embed education and support around hypertension and blood pressure control, especially when the provider may have very limited time to spend with that patient, whether it's a walk-in?
Yeah, so this is what team-based care is all about. And this is really about the benefit of having a treatment algorithm that the whole team is familiar with. So it starts when they walk in from somebody at the front desk knowing whether or not they have a history of high blood pressure, or when the MA or the RN takes the blood pressure and they notice that the blood pressure is high. Since we're talking about hypertension, I'm going to address, that's what we're going to talk about here. So they walk in, they've got an elevated blood pressure. Before the clinician even gets to them, if they've got a high blood pressure, and an MA or an RN who's familiar with the treatment algorithm can know, are they on a medication? Are they taking that medication? Are they on track? Have they been seen in the last 6 months? They can look to the treatment algorithm for guidance if they're a newer patient to say, are they on the right medication based on the treatment algorithm? Have they been seen at the right frequency? Is their blood pressure controlled or not controlled? So a whole lot of things can happen prior to the provider coming in. So if they're there for abdominal pain or a cold or a migraine, it would still be really important to know if the blood pressure is elevated. Now, it could be elevated for other reasons, but it's still an opportunity where somebody could very quickly, that's why the whole team needs to be familiar with the treatment algorithm, because they can all play their role. If they put a little sticky note or a note in the chief complaint box of the EHR saying, after the chief complaint, they could note this patient has uncontrolled blood pressure, has been non-adherent to treatment, or has not filled their blood pressure medicine in 6 months. A brief note can make all the difference in the world, so that when the clinician comes in the room, they can have a very brief targeted conversation about, you need to come back and see me for your blood pressure. In the meantime, I'm going to refill your medications, or your medication. Why did you stop taking it? And that can happen in a very brief amount of time. But that's really a question about team-based care.
Okay, thank you so much. And one of the questions was asking how the Target BP program differs or is similar to the Million Hearts campaign.
So they're really, they're not competing programs, they're more complementary programs. The Million Hearts campaign is a national initiative where there's a website and a public health initiative where you can go onto the Million Hearts website and use their tools and resources on your own to try to improve blood pressure control. Where Target BP is different is that there's on-the-ground affiliate staff and American Heart Association professional volunteers that really come into the site and provide support. And in addition, the recognition program is different. in that instead of, the Million Hearts Recognition Program, which is still in existence, will recognize 20 to 30 organizations or sites a year, whereas the Target BP program could potentially recognize hundreds of sites for achieving the same target goal for improving blood pressure, the target control rate. So they're different in those ways, and Target BP continues to leverage their network of affiliate staff and volunteers and the AMA's experience in working with practices, creating tools and products that help to improve blood pressure. And to be honest, the AMA, it helped build a lot of, many of the Million Hearts tools as well. So we're very familiar with what they have. And again, it's all complementary, but I'd say the biggest difference is the experience of the AHA in writing guidelines and the treatment algorithm that they've been promoting for several years. They're writing the new hypertension guideline with several stakeholders, and if there's a new treatment algorithm that'll come out that'll accompany that guideline, AHA will be a part of it. Target BP will be promoting it, and then all of the support that you get from AHA and AMA along with that. So I think those are the main differences.
Great, thank you. So that is all the questions that were submitted before the webinar. We're going to now go through the chat box. We've been getting a lot of great questions in the chat. Thank you all for submitting those. So we're going to start at the top and read through these questions. So we have about 10 more minutes, so we'll get through as many questions as we can. We just wanted to let you all know that if there's any questions we don't get to in these 10 minutes, then we'll do our best to get back to you all whose questions weren't answered. So just starting from the top, Tim had a question asking if we can highlight the difference between registration versus recognition data.
The recognition program data will require a breakout of the population in the practice by age. So, I may not be exactly right here, but 18 to 24, 25 to 30, 31 to 40. So it'll ask for a specific breakdown in that way. It'll also ask for a breakdown of the population by race and ethnicity, and so those are largely, and a control rate will be required for recognition, and the numerator and denominator for the practice, the number of patients with hypertension. These things for recognition are very specific. For recognition, the criteria will be based on PQRS 236 or NQF 18. So it's patients age 18 to 85 for having high blood pressure. It excludes patients who are pregnant, patients with end-stage renal disease, etc. So there are some very specific criteria for the recognition program that are slightly more robust than for registering for Target BP. But we encourage everybody who registers for Target BP to also join the recognition program. There'll be much more information coming soon for, we'll have a webinar probably for participants probably in early April, shortly after the recognition program launches at sometime in late March, to explain very specifically how to enter your data. And the affiliate staff, if you register for Target BP, the affiliate staff will be able to walk you through that process of entering data for recognition. So the best thing to do would be to sign up for Target BP as soon as you can, and then you'll receive that email when it's time for recognition entry, data entry, and you'll have more help from the affiliate staff to do that, along with webinars.
Great, thank you.
Yep.
So our next question comes from Brenda, and she's asking, how often do you recommend the patient bring in their home blood pressure monitor to assess accuracy of the unit or the patient's technique?
So it has to be done once in the beginning before treatment decisions are made based on home blood pressures. So always once in the beginning, and then we usually say once a year to make sure that the device is still working correctly. It needs to be tested against a standard in the office, so whatever the office uses, to make sure that the two machines are within, about hopefully 5 millimeters of each other after several office blood pressures are taken and several self-measurements are taken by the person using their home device, and then you can compare the two and take averages with 3 measurements from the home device and 3 measurements from the office, and then if the average of the two are within 5 millimeters, you should be fine. But once a year, long answer to the question. But always at the beginning before you start relying on those measurements.
Okay. Now, Gloriella, thank you, sorry, for the question, is there any evidence in the literature that asking patients to use a BP kiosk as part of SMBP is effective, specifically if all members don't have access to self-monitoring equipment in the home?
So there's not a lot of literature on this subject, but there is one paper that compared a particular kiosk, so not all kiosks. There's an FDA warning about kiosks because many kiosks are designed for what's called recreational use, and they have medium-sized cups, and they can only do about half the U.S. population correctly. So you've got to be very careful if you're going to use a kiosk. Follow that FDA warning. You can Google it. You've got to make sure it's the right size for your arm. Having said that, there is some literature that compared a particular brand of kiosk, which can handle over 90% of the population. In the peer-reviewed literature, they studied a kiosk made by a company called PharmaSmart, and they compared it to 24-hour ambulatory monitoring, and what they found was that this was an acceptable option to use compared to 24-hour ambulatory monitoring, which is the gold standard for out-of-office measurement. So in that case, a PharmaSmart kiosk compared to 24-hour blood pressure monitoring, the gold standard, was shown to be comparable and did correlate very well. So in that one case, we do have peer-reviewed literature saying that that is an acceptable option, but beyond that, there is not a lot of literature or any literature that I'm aware of saying that you can use a kiosk. There may be literature, but a position paper by the American Society of Hypertension, that you could also Google. You Google blood pressure kiosk and the American Society of Hypertension, and we can send out a link for this. It's a position paper. Talks about the safety of using kiosks for self-measurement of blood pressure. They talk about this peer-reviewed manuscript that I'm mentioning and the safety of using kiosks. So yes, there's some literature. It is relatively limited, but there is a way to do it safely. You just have to make sure you're using the right kiosk that has evidence if you want to do it. Otherwise, it may not be as reliable. So you have to be careful. I guide you to those publications and the American Society of Hypertension document specifically, which is a guide for clinicians. Yeah.
Thank you for being so thorough in your responses, Dr. Rakotz. We'll probably take 1 or 2 more questions depending on the time. Mary Ellen has a question. Can you speak more to community-based options for measurement? Where can patients go for measurements if they can't afford a device? Are there any partners in this?
Sure. Well, there's, again, and I think this will be, if you're in Target BP and you have a connection to American Heart Association affiliates, or even if you're not, the American Heart Association's Check Change Control Program is a community-based blood pressure self-monitoring program that is nationwide. We can connect you with the American Heart Association to find out, depending on where you are in your community, about the program itself. It's about using self-measured blood pressure monitoring in the community, and that's one option. And the other option is the YMCA's blood pressure self-monitoring program. This program doesn't occur in all locations, but it is another option. These are 2 of the community programs that we have worked with, and they both focus on educating people to properly self-measure and focus on, empowering patients to self-manage and education on lifestyle and other things. So those are both good options. Check Change Control and the YUSA's blood pressure self-monitoring program.
Great. I think we have time for one last question. Sorry again that we won't be able to get to everyone's question today, but we will follow up with you. So Damaris has a great question. Is there a correlation between patients' height and ethnicity to their blood pressure? For example, if the patient is shorter than an average height, is it normal for their blood pressure to be less than 120/60?
No, I'm not aware of any relationship between height and changes in what is considered a normal blood pressure, or body type for that matter. Typically, people based on body mass index and weight, elevated body mass index is a risk for developing hypertension, so it is a risk factor for developing hypertension, but it doesn't change the threshold for what hypertension is. And height doesn't.
All right. So just in respect for time, thank you all for joining us today, and thank you again, Dr. Rakotz, for your presentation.
I'm sorry to interrupt. There's one question that's been asked repeatedly online that I just want to address, and I think it has to do with for quality measures and for recognition. In the quality measure, the blood pressure measurement that qualifies for the quality measure over the course of a year is the last blood pressure, the last one in the measurement period is the one that qualifies, that determines whether or not a patient is in control for the previous year in the measurement period. So whether somebody's been out of control for a whole year, as long as they get in control by the end of the measurement period, they qualify as being in control. Even if it's a single blood pressure at the very end of the year, they would be counted as being in control. So I apologize. I just wanted to get there for you. And thank you very much.
All right. Thank you so much. So I just have a few last announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill it out, we would greatly appreciate your feedback. And if you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you will receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website, which is www.healthcarefornewengland.org. The PowerPoint presentation was in your login details email and is posted on the website, as I mentioned. So within the next few business days, a recording and transcript of this webinar will also be added. Great. Thank you again all for attending, and hope you all have a great rest of your day.
Connected. The conference will be terminated in 5 minutes.